Good morning, everyone. I'm Dipan Shah here at Houston Methodist DeBakey Heart and Vascular Center, and welcome to our weekly Grand Rounds. Before we get started with today's speaker, just a few housekeeping comments. First off, again, we want this to be an interactive forum, so please feel free to type in or text in your questions. You can text DeBakey to 37607 to enter your question, to text your question, or you can text via or send questions via the web by going to pollev.com and enter the keyword DeBakey with your question. So before I introduce today's speaker, I also want to introduce Dr. Rayan Yousefzai, who's one of our heart failure transplant colleagues, who's here with me in the studio for a little commentary and question and answer after the talk today.
Thank you.
So let me start off with Dr. Speaker today, which is Dr. James Carr. Dr. Carr really needs no introduction in the cardiovascular radiology community. Dr. Carr is chair of the Department of Radiology at Northwestern University, and he's a professor of radiology and biomedical engineering there. Dr. Carr has a long history of clinical investigations, and he's received numerous federal and industry grants. He's also an active teacher as well, having been the fellowship director for the cardiovascular imaging program, as well as a clinical and research MRI program at Northwestern. He's trained over 70 clinical and research fellows at Northwestern, and he's really a national leader involved in the American Heart Association, the American College of Radiology, the International Society for Magnetic Resonance. He's the past president for the Society of Magnetic Resonance Angiography and the current president of the Society of Cardiovascular MR. So, without any further ado, I'd like to turn the floor over to Dr. Carr. He's going to speak with us a little bit about the role of MRI in evaluation of the transplanted heart. This is an area which he has quite a bit of clinical expertise as well as research investigations in. So James, can you hear me okay?
I can hear you fine.
Great.
Thank you, Dipan.
Well, James, welcome. We'd hope to have you here in person, but we're glad to have you here virtually, and I'm going to turn the floor over to you. We look forward to your grand rounds.
Yeah, well, thank you very much, Dipan. It's a real honor to be here, at the Methodist DeBakey Center. It's obviously world-renowned, and I know Dipan for many years, and it's really great to be able to talk about cardiovascular MRI to such a luminary audience. So I'll go ahead and just share my slides, Great, and hopefully you can see the slides okay.
Yeah, we can see it fine.
Great, so I'm going to talk to you on MRI of the transplanted heart today, and this is just initially just a quick summary of what that entails, but then most of the talk is going to be presenting other people's data and some data we have from Northwestern. I'd be curious to compare notes at the end. This is my disclosure slide. None of this will really impact my talk. I would disclose, as Dipan mentioned, I'm the current president of the SCMR, and I am going to be talking about cardiac MRI. And a lot of the work I'm presenting from Northwestern is funded by one of our R01s, which supports our work on MRI of the transplant heart. So in terms of outline, I'm going to just review some of the heart transplant complications. Then I'll talk briefly about current imaging tests for evaluating the transplant heart. I will then talk about the role of MRI in heart transplantation, just briefly finish up on future directions. I am going to focus on imaging, but I am aware that there are many non-imaging tests now used to evaluate the transplant heart, and perhaps particularly AlloMap testing, etc. I am not going to talk about in this particular talk, but of course this may be something for the discussion, and of course I understand that it is relevant. So in terms of heart transplant complications, there are approximately 2,500 heart transplants performed in North America each year. And about a fifth of these have one episode of acute cardiac allograft rejection in the first year. In fact, this can result in 40% mortality in the first 30 days and 18% mortality thereafter. The incidence of acute rejection tends to diminish over time, but particularly is a problem, as you know, in the first year post-heart transplantation. After year one, the primary complication that we are concerned about is chronic allograft vasculopathy. And this remains a significant complication with an associated significant mortality. So this accounts for about 30% of deaths in the first 5 years post-transplant. But after, as time goes on, CAV becomes more prevalent, and it's a reason why we need to test for this fairly regularly. Acute rejection is commonly asymptomatic, and if untreated, can result in fairly significant consequences such as heart failure, arrhythmia, and potentially death. So again, another reason for active surveillance of the transplant heart. And early detection and accurate surveillance are crucial to the management of these patients. So just a quick review of the classification of acute rejection, first of all. So it's based on histological classification and divided into, first of all, no rejection, and then grade 1, mild, grade 2, moderate, and grade 3, severe, based on the amount of lymphocytic infiltration. They're also, patients can also be susceptible to antibody-mediated rejection, and this follows a similar type of classification system. Rejection results in inflammation and edema in the myocardium, and with repeated episodes of this can ultimately lead to fibrosis, which may ultimately lead to left ventricular dysfunction and heart failure. And in order to evaluate this, endomyocardial biopsy, which is the gold standard and is still considered the conventional way of evaluating for this complication, may be performed 12 to 16 times in each patient in the first year. So quite significant invasive testing for these patients. The second complication I mentioned is cardiac allograft vasculopathy. This is a vascular disease which is unique to transplant recipients. So it results in a diffuse pan-arterial intimal proliferation. Initially, that is the first finding, and this eventually results in luminal stenosis of the epicardial vessel. So it does tend to affect the medium to smaller size portions of the vessel, of the coronary artery, so may not result in a significant visual defect on imaging, at least initially. CAV is fairly infrequent in the first year, so detected about 7% in the first year, but 30%, as I mentioned, within 5 years, and then 50% at 10 years. And it may, in its advanced forms, be difficult to distinguish from atherosclerosis. Just a little bit about the pathogenesis of this. So there are the transplant-associated risk factors for CAV. These also include repeated rejection episodes, but also other features as noted here, such as immunosuppression, ischemia, donor age, etc. The classical risk factors also play a role here for cardiovascular disease, as outlined below. And the process is really inflammation, both lymphocytic and macrophage activation, which results in endothelial dysfunction and ultimately this vasculopathy and damage to the left ventricular myocardium. Okay, so what are the current tests, particularly imaging tests that we have, that we use for evaluating the transplant heart? So as I mentioned, acute cardiac rejection tends to occur in the first year after transplant, and then beyond the first year, cardiac allograft vasculopathy takes over. And this is the single risk factor for 5-year mortality. So therefore, these patients have to be monitored for both, but they're monitored in accordance with a slightly different timeline of when these complications actually occur. So this schematic just shows you how we evaluate this. So in the first year, the surveillance is fairly frequent, as I mentioned, particularly can be, for example, a biopsy every week in the first month post-transplant and reducing in frequency thereafter to look for rejection. But then after year 1, as CAV takes over, the imaging surveillance can become less frequent, but then different imaging takes over, which includes catheter angiography and intravascular ultrasound and or biopsy also as you get further out from the initial transplant. So what are some of the limitations of the current strategy? Well, acute rejection requires frequent evaluations, which are invasive, frequent biopsies, and these are costly. There may be limited sensitivity due to sampling errors, as you probably know. And then CAV requires catheter angiography, and IVUS, also costly and invasive, and may be difficult to detect the diffuse nature of the disease, particularly on angiography, and hence the advantage of IVUS. So, if there was a reliable non-invasive alternative for detection of both these complications, that would be desirable. And a secondary benefit would be reducing the need for invasive procedures, not eliminating them, but reducing the need, which may improve the potential sensitivity, but also reduce the cost of managing these patients over time. A little bit about endomyocardial biopsy, which is the standard for monitoring acute cellular rejection. As I mentioned, this can be performed very frequently in year 1. The rate of complication is reported as high as 6%, but overall, this is a very safe procedure and the complications are relatively low. Repeated biopsy can result in tricuspid regurgitation, right bundle Blanchbach, coronary fistulae, and myocardial scarring. And as I mentioned, the cost can be pretty significant since this is an invasive test. Echo has been well documented to have a role in the detection of acute rejection. I'm not going to go through all the studies in this slide, but you can see that Echo really focuses on measuring particular parameters that may be derived from Doppler parameters such as E values, A values, EA, IVRT. These are various parameters that are measured. Tissue Doppler imaging is used. Strain rate imaging is also used. They all have variable sensitivities and specificities, are best used in varying combinations, and of course also depend on the expertise of the operators and the expertise of the center. So depending on whose hands this tool is used in. And this schematic just shows where these various imaging tests may be incorporated to evaluate acute rejection. And again, the pathogenesis is outlined here. And the idea is that you want to really try to detect disease at a very early stage so that you can intervene with drug therapies to eliminate the disease process. So biopsy occurs at this level, so hence that's why it's the gold standard. And then I'll show you, hopefully, that some of the imaging tests, particularly cardiac MR, may be able to show you at a slightly later stage, but still relatively early, the presence of edema and potentially myocardial necrosis. Echocardiography, of course, is used primarily to focus on allograft dysfunction. And then in the later stages, a lot of the imaging tests can be used to evaluate later dysfunction. I talked a little bit about coronary angiography. IVUS is used in corporation with coronary angiography to detect CAV. In fact, many would say that this is critical because this is a pan-arterial process that more circumferentially involves thickening the vessel wall. That really IVUS is critical because standard coronary angiography, as shown here, may not actually show significant stenosis at an early stage, but you can see here in the image on the bottom that there actually is wall thickening, but potentially without causing a significant stenosis. So IVUS does detect intimal thickening at a very early stage, and in some studies has detected an 80% as early as year 1, although this may not be clinically significant. There is a classification system also for CAV, and I'm going to outline this here. I'll refer back to this later. Really depends on the number of vessels involved and the severity of the stenosis. Again, I'm not an expert on this, but again, similar classification system used as aligned with rejection. Just of interest, CT angiography has been used in the setting of CAV, and there are some even more recent studies looking at this. The advantage of CTA, of course, is that it can show both the vessel wall as well as luminal narrowing or luminal stenosis. And here you can see again on the angiogram, not a ton of disease on the catheter angiogram. And in this particular publication, you see scattered disease on the CT. So calcifications or even wall thickening. On this particular example, the resolution isn't great with CT on this particular image. But as you know, CT is improving all the while. And I think with the more recent advent of FFR, for example, there may be an advantage to CT. I would say probably the principal disadvantage to CT and clinically is the use of iodinated contrast. So it still does require more iodinated contrast than a catheter angiogram. And these patients, many of them have renal dysfunction. So to use iodinated contrast with CTA may be less desirable. Although again, the volumes of contrast over time are decreasing even with CTA. And this table just shows you a summary of the sensitivity and specificity for some of even older studies now for detecting CAV on the basis of luminal narrowing and wall thickening. And you can see it's quite variable, but overall acceptable. And again, similar schematic, just showing you where the various tests may fit into the diagnostic algorithm. IVUS, again, considered the gold standard. CT potentially may play a role because it does have the ability to visualize the vessel wall. MR in this setting, just draw your attention down here, really focuses more on the detection of ischemia. And as I mentioned, I'm going to talk about that in a little bit. Okay, so what is the role of MRI in heart transplantation? Following now just a quick recap and review of what we currently do and what's is currently considered standard of care. Well, first of all, the value of MR is its ability to incorporate multiple techniques into a single imaging study or protocol. So as many of you may know, MR is not just one single push button imaging test. It really utilizes multiple tests within a single test to evaluate different portions of any part of the anatomy, quite frankly, but particularly the heart. So we can look at function over here on the left, and we can look at what used to be called viability, but now late gadolinium enhancement. So this is kind of the bread and butter for cardiac MRI, and you use this routinely every day for looking at for infarcts or heart failure evaluation, et cetera. We can also incorporate perfusion imaging in here to look for ischemia, more traditionally due to atherosclerotic disease. And then we can add on any of these other tests, so angiography here for looking at the aorta or even looking at the coronaries. And we can even look at the anatomy in greater detail with some of these techniques here. So this would be more conventional cardiac MRI, and we use this for many of these other routine indications currently outside of heart transplantations. In more recent years, we've seen a number of newer techniques become available, and these are shown here. So I'll just mention rapid cine imaging just because this has the potential to really speed up the cardiac MR protocol in general. But also particularly in the transplant heart where patients may not be able to tolerate the entire protocol very well. But a lot of excitement is focused on these mapping techniques on the bottom. So T1 mapping, and then from T1 mapping, you can measure what's called the extracellular volume. And then you can also use T2 mapping to evaluate in particular edema. T1 mapping and ECV are generally considered surrogates for fibrosis. T2 mapping is generally considered a surrogate for edema. So you can see potentially putting these together on top of your functional assessment, you could potentially reach a point where you could really characterize what's going on in the transplant heart. The other advantage of these techniques is that they are quantitative. So similar to a lab test, for example, if you get over a certain value, that's considered abnormal. So this is really the equivalent, T1 mapping, ECV, and T2 mapping are the equivalent of imaging biomarkers, essentially, for really detecting disease. Just mention a little bit about velocity measurement, and I'll talk briefly about this. This is not mainstream right now, but there are various techniques we can use to look at velocity, to measure desynchrony or abnormal function in different regional parts of the heart. These are analogous to strain imaging, and there are techniques for looking at strain imaging with MR similar to echo. As I mentioned, these are not really in the clinical routine right now, but may play a role as we move forward. And these are just some images from a tool that we have used at our institution called tissue phase mapping, which looks at the velocity of the myocardium in multiple different directions in a single acquisition. And you can then calculate these various color code maps to get an idea of the function. So some of the early work we did on heart transplants was actually derived from these velocity techniques and provided some of the inspiration for really moving forward on our work on MRI and heart transplantation. So this was an early study carried out by Danielle Fohl, who was a visiting cardiologist to us from Freiburg in Germany, and she looked at a number of heart transplant patients, comparing them to volunteers, and looked at the velocities. And you can see here that the velocities in the red in the transplant were just lower across the board in the transplant patients compared to the volunteers. And of course, that may not be surprising. This was more to say that this was a proof of principle that we could actually do this with MR. But of course, we knew some of this already anyway from echo. Another study she did, which was published, looked at, again, a similar transplant population between Northwestern and actually Freiberg, looking at cold ischemia times, and divided the population based on the cold ischemia times, and which we know can be a portender of bad things if there's a long cold ischemia time. So with longer cold ischemia times, more than 155 minutes in this particular study, the velocities were worse in this transplanted heart in the recipient compared to shorter cold ischemia times. So again, suggests that this may detect things that are happening at an early stage before some of these other imaging parameters. Some other groups, this is some work from the Ohio State University, tried to really just copy what echo could do with MR. And in order to do that with MR, you have to scan really fast, because echo has a very high temporal resolution, so very high frame rate. We can do that with MR, but in general, if you do it with MR, you sacrifice the image quality. So this is a study where they did rapid cardiac MRI, and they compared, for example, the E' measurement with echo with the E' measurement for cardiac MR, and found a fairly close match. So you can do this with MR, but of course, this is something we already do with echo. And also, we looked at this in a small group, again, looking with a similar parameter, isovolumic relaxation time, which has been used to detect transplant dysfunction at the early stage, and also found a reasonably close match between echocardiography and cardiac MRI. So moving on to more of the quantitative imaging with MR. So the first one I'll talk about is T2 mapping. So if you remember, T2 mapping, our T2 measurement, is used to calculate a T2 value, which is used as a surrogate for edema. So generally speaking, a T2 value above about 60 milliseconds is considered abnormal. Now there's a range in there, so 55 to 60, but for practical purposes, probably 60 is a good one to take. And this is just an example of a giant cell myocarditis. For those of you used to looking at cardiac MRs, you'll see the abnormal motion here in the septum on the cine image. Here's the late gadolinium enhancement, which shows mesocardial enhancement in the septum. And this is an unusual location for myocarditis enhancement. Most myocarditis tends to occur in the lateral wall, but this is pretty typical of giant cell myocarditis. This was proven by biopsy. But notably, you'll see here, and you can even see this visually, this high T2 value in the septum. The T2 value here was measured at 76 milliseconds. So in this single case example, we know from this that we can see edema, we can measure the edema, and this can be used as an adjunctive measure when helping to make a diagnosis clinically for a number of different pathologic states, which primarily include myocarditis, which of course is even now more relevant in the setting of COVID. This was used as a motivation for evaluating the transplant heart, because if we could measure edema with T2 mapping in myocarditis, we know that rejection is similar to myocarditis, so therefore we should be able to detect rejection on the basis of measuring edema. So this was a study we did in a small group of transplant patients early on, and found that if you used a cutoff of about 56 milliseconds, you got a sensitivity of 86.5% for detecting rejection, any type of rejection, using endomyocardial biopsy as the standard of reference. Here are the patients grouped by different types of rejection, and you can see that patients who had any type of rejection developed a T2 value which jumped up to about 60 milliseconds. This was now a global T2 value across all types of rejection. And then interestingly, I just include here a number of these. A small group were rescanned, and you can see that about 2 weeks later or so, the T2 value decreased back down to a more, what we'll consider a more normal level or baseline level. So it seemed, at least at this early study, that T2 could detect rejection and edema, and also seemed to revert to a more normal baseline value after treatment. Some of these findings have also been shown in additional studies. Here's a study out of France who have, this particular group have done a lot of work on MRI in the transplant heart, and they looked at the T2 values across different grades of rejection. And you can see that it does track up. The higher values of T2 tend to occur in the higher grades of rejection. And you can see in this particular study, they were getting grades, T2 values very high, which is somewhat unusual. And I would also say clinically, we don't see very high grades of rejection on a frequent basis. And that was also evident in our study, which we did, which I'll show a little bit later. And this is just the ROC analysis showing a good AUC for detecting, in this case, any type of moderate to severe rejection. Another study, this one from Lausanne in Switzerland, looked at 113 patients with rejection, and again showed similar findings, which were fairly similar, I think, to our study. Again, average values of T2 in the more moderate rejection up to about 60 milliseconds or slightly higher, and then moderate or milder grades of rejection had lower levels of T2, and then no rejection was more in the 40s. Again, showing similar types of results. Another study looked at, again, the accuracy. This is comparing T2 now and T1. The T2 value compared to T1 was better at showing, detecting rejection on this ROC analysis. Interestingly, the T1 value also seemed to show rejection. And as I mentioned previously, T1 on its own, this is native T1, is used as a surrogate for fibrosis, but will also be prolonged in edema. So it's not surprising that that might occur. And if you look at the actual values in this particular paper, they quoted average T2 values. So this would be the average global T2 per patient across all segments. And then they also looked at the peak T2. And when you look at the acute rejection here, you can see the peak T2, just visually looking at these numbers, was a bit more discriminatory compared to just the average T2. So you get higher peaks of T2 compared to if you just average it across the entire patient. This also, another study looked at the prognostic value of T2 and showed that you had a higher complication rate over time, so adverse complication rate if you had a higher T2. And of course, this is probably not surprising because the higher the T2, the more likely you were to have more severe episodes of rejection and potentially also repeated episodes of rejection, which may contribute to this poor prognosis over time. But notably, if you had a low T2, in this case less than 55 milliseconds, you had a pretty good prognosis. So that's useful information to know. Moving on to the other tissue parameter is extracellular volume mapping or extracellular volume measurement. So extracellular volume is calculated from measuring the T1 of the myocardium pre-contrast and the T2 of the myocardium post-contrast, and using a slightly complex equation which incorporates the hematocrit, you can measure the extracellular volume of the myocardium. Typically, the extracellular volume of the myocardium should be less than about 26% or so. Anything above that is considered abnormal. And this is one of the original seminal papers in the cardiac MRI world, where they looked at a number of different disease states. Here's a LGE image just showing you all the fibrosis in the myocardium. But you can see, for example, normal, as I mentioned, is around the 26, 27 range. But as you go to some other conditions, so most extreme is myocardial infarction with scarring, has a very high ECV because most of the extracellular space is replaced by fibrosis. But then intermediate conditions such as hypertrophic cardiomyopathy have varying degrees of fibrosis. And this is currently being studied. As you know, increased fibrosis or ECV numbers in hypertrophic cardiomyopathy are associated with worse prognosis over time. Also, clinically, we use ECV on a day-to-day basis for diagnosing amyloid, for example. So you get very high ECV values in amyloid, which can be diagnostic even in the absence of late gadolinium enhancement. So when we look at these tissue parameters, again, in this study, this is a smaller study, you can see when you look at T1, and we already looked at T2, it seems to track, as we saw before, the grade of rejection. Okay, so healthy, milder grades of rejection, higher grades here for T1 and T2. You get higher T1, T2 values with higher grades of rejection, and similar findings for ECV on the top. So the higher the ECV, is associated with higher grade of rejection in transplant patients. So we did a study at our institution, really trying to take into account a lot of the studies to date, including some of our own pilot studies, and then incorporating some of these new parametric mapping techniques with MRI. So this is the protocol we used in our transplant subjects. We used Cine imaging for function, but also looked at T1 mapping, T2 mapping, late gadolinium enhancement, and we also did tissue phase mapping for looking at regional myocardial velocities. So here are some of the early results from this study. The study cohort was divided into a number of controls, so 14 controls, and then the patient population was divided into those that had active rejection, so about 23 of them, those that had a past episode of rejection within about 3 months or a more severe grade of rejection, are those that did not have rejection but were still transplant subjects. Okay, that was the grading, and then the results are shown here. Here are just some examples across the board. If you look at controls on the top and active rejections on the bottom, you can see, similar to the prior studies, that the global T2 measured here, now this is more the average T2, in the controls is 44 milliseconds, which is what you'd expect for a normal person, tracks up to about 58 milliseconds on average in patients with active rejection. Similarly, the T1 tracks upwards as shown, so higher T1s in those with active rejection versus normal, and also similarly, higher ECVs in those with active rejection versus normal. So you can see here, normal ECV in the controls was 26%. The ECV in those with active rejection was 33%. When you look at this on a segmental basis, if we first look at the T2 values, again, the T2 values, again, if we go to the active rejection, were elevated across the board. Seem to be a bit more prevalent towards the mid and apical portions, but again, increased compared to those with past active or past rejection, but not massively increased, a slightly marginal difference, certainly significantly increased compared to those with no rejection, and also significantly increased compared to the controls. And similar values were found for ECV. Here are the ECV values, again, segmentally in those with active rejection, again, above 30% in most segments, not just in the septal segments, but also in the lateral segments and anterior and posterior and anterior and inferior. less elevations in ECV in our patient cohort seen in those with a past rejection or no rejection episode. So ECV seemed to be more discriminatory for those with active rejection. In terms of our ROC maps, we found a greater area under the curve for ECV in this particular population compared to the T2 value. This was slightly lower compared to some of the prior published studies. It's a larger cohort of patients, but the prior studies were getting, as I mentioned, more 0.8 to 0.9. We got 0.7. I will note that our grades of rejection in this population were mild to moderate. We really had no severe rejection. I think this is just a sign of the times and just how good we are at treating rejection in general, that we don't see the more severe grades. But certainly our research population was more in the mild to moderate variety. If we look at these velocity measurements, again, in a similar portion of the cohort that had tissue phase mapping, we saw more dysynchrony, lower longitudinal velocities in particular, and higher T1 and T2 in the transplant populations compared to the controls. And this is just an example of a single patient, transplant patient on the bottom, controls subject on the top. And again, you see the ECV values, 24 or so compared to 27% in the transplant patient, and higher T1s in the transplant compared to the controls. ECV and T2 do seem to have some prognostic value. And you can see here in this other study, also based on our cohort, looking at ECV on the top and T2 on the bottom. When you look at ECV for all adverse events versus cardiac events, you can see that if you have a lower ECV, less than 25%, you are less likely to develop complications. So this is freedom from all events compared to if you had a higher ECV. And this applied to all events versus cardiac events, and the same with T2. Again, more adverse events if you had a T2 value more than 50 milliseconds in this case. So this was shown in prior studies, again, not surprising, but does seem to be persist. We also looked in a separate study at late gadolinium enhancement, since we had all that data, and we showed that about 35% of all transplant patients had late gadolinium enhancement, mostly in a non-vascular distribution. This is based off of a cohort of 92 patients. This shows you the type of enhancement. Most of the enhancement, when it did occur, was at the right ventricular insertional point, so the infraseptum. This is a kind of typical type of scar we see in patients with septal abnormalities or pulmonary hypertension. We were also seeing it in the transplant population as well. Not sure what the etiology of that is, but again, could be partly due to septal abnormalities or an abnormal function of the septum. We also saw, as I mentioned, mostly mesocardial to subepicardial. So this is a non-vascular distribution of scar. You can see here no real subendocardial scar. Again, would be more typical of the rejection myocarditis type etiology, not typical of the ischemic type. And again, those that had LGE had a worse outcome over time compared to those that had not. So that's just similar to all other types of pathology. Any type of pathology where you detect LGE has a worse prognosis over time. This seemed to hold true for the transplant population. Moving on to stress perfusion MRI, just to talk a little bit about chronic allograft vasculopathy. This is just a case example of a patient that had severe CAV in their LAD. This patient died, and you can see the massive intimal proliferation within the LAD. Pretty good function, and also no really significant late gadolinium enhancement. When you look at the stress images, there is a defect here in the anterior distribution that does go away at rest, but again, is not really dramatically visible, I would say, but it is abnormal. And it was detected on stress perfusion MRI. So because CAV is a pan-arterial process and can affect all vessels, it's possible that standard perfusion imaging may not actually be terribly useful for the reasons that I mentioned in the prior case, that you may not see the same regional defect that you might typically associate with atherosclerosis. So a lot of groups have focused on different regional parameters. So this is one study looking at myocardial perfusion reserve across different grades of ECV. And you can see that the MPR is most reduced in the higher grade of ECV compared to the controls. Similar in this other study, again, you see normals had a myocardial perfusion reserve of about 3 to 4. Remember, with pharmacological vasodilatation, you expect your coronary flow to increase 3 to 4-fold. But when you get down to higher grades of CAV, the MPR dropped below 2. They quoted 2.3, but I would say less than 2 would be considered abnormal in the setting of the transplant heart. And again, shown here in another study where the myocardial perfusion reserve seemed to track with the IVUS plaque volume and also the small vessel IMR parameter relatively linearly when measuring this parameter. We also looked at CAV based on our tissue parameters, and this is a study that was presented recently, is in press, looking across the different grades of CAV this time. This is pushing the population out a little bit over a year post initial transplantation, and saw that the ECVs were higher in the higher grades of CAV versus those in the controls, which is interesting and may reflect just this ongoing fibrosis that may potentially occur with repeated episodes or persistent CAV. So just to finish up briefly on some future directions, we've seen some work look at MR elastography in the heart transplant. So MR elastography is used in the liver to measure stiffness and is used as a surrogate for detecting cirrhosis. You can do this in the heart as well. This is just one example where they showed that the stiffness measurement increased in a patient with rejection and reverted to normal following treatment. Now, this is not easily reproducible clinically, but just shows you that there may be other parameters that could be used with MR that may be useful. Another technique that is being used to look at transplant rejection is PET-MR. So combining these two parameters together, we're probably more familiar with this when evaluating cardiac sarcoid, but this has been done in for other applications in other institutions. Here's an example of uptake in the lateral wall that might be missed by a biopsy in a patient with rejection as shown by the biopsy. So again, probably very sensitive for detecting rejection, may not be practical given that PET-MR is a fairly expensive, sophisticated test that's really only limited to large institutions. And then finally, some work we're looking at. A lot of our research work focused on MR in general has been using the 40-flow MRI technique, looking at 40-flow in the heart. And we've also been applying this to the transplant heart and have been finding, as probably not unexpected, significant flow disturbances, and in this case, energy loss, which can be measured or can be derived from flow measurements in patients who've had transplant and have had left ventricular dysfunction versus those that are normal or do not have left ventricular dysfunction. We see this in heart failure, and we see this in other conditions such as pulmonary hypertension as well. So to finish up, heart transplant, as I mentioned, requires intense surveillance due to the high incidence of post-transplant complications. Current monitoring techniques are invasive and time-consuming, resulting in potential complications and high cost. Newer CMR techniques may help reduce or replace invasive tests for assessing transplant patients. And the integration of cardiac MRI into the current management algorithm for evaluating of the heart transplant patient may potentially reduce cost and improve the accuracy for detection of adverse events. So thank you very much for your attention, and I appreciate the time and the opportunity to talk to you about some of our work and just the role of cardiac MR in heart transplantation in general.
Okay, that was outstanding presentation, James. Really appreciate it. And we've got some time now for from the audience. If there's any questions, please feel free to go to pollev.com and enter the hashtag, the keyword DeBakey, or text your questions by texting DeBakey to the number 37607. We've got one question here. Let me see if I can get around to seeing what it says. It says, can you see it?
Yes, I
Rayan?
can. Yes. So the question is basically the acute cellular rejection has become less a problem. Do you have any data suggesting prognostic role of high ECV in the patient who had no typical rejection, meaning the adverse immune interaction with the heart and beyond cellular rejection and with need for imaging marker in this adverse reaction? So I guess it's basically it's asking if it's the cellular rejection has been there and it has been validated in a lot of studies, but the antibody-mediated rejection and non-HLA rejection, which has kind of been more challenging for us to define and diagnose as in the transplant. There any data for those type of rejection versus acute cellular rejection that imaging can help with us with?
Yeah, so this particular study did include some patients with acute antibody-mediated rejection, and we do see higher values of T2 and ECV in that particular group as well. The numbers are very low. I think that's probably reflected just in clinical practice that it's less common than cellular rejection. So I don't have any data to support whether ECV could distinguish the two from each other. But we did see similar findings of abnormal T2 and ECV in that small group that we had in our cohort at least.
Okay, great. So Rayan, I'm going to turn it over to you to ask some of or make some of your comments.
Yes, well, thank you, Dr. Carr, for an amazing talk. I just want to make a general kind of a comment and a question from you, as you elegantly showed in your studies, and this study has been shown in a MRI with the pretty established and a high sensitivity and specificity to identify rejection and even evaluate the whole myocardium, which can be missed on some of the sample error that we're doing from the biopsy. However, it has not been, and the newer technology, the mapping and ECV is also adding more values to detecting the rejection. However, in the transplant world, it has not been widely used MRI for detection of the rejection or resolution of the rejection. Where do you think the gap is, and is it we need more data, or the technology is still not there to completely identify or diagnose these rejections?
Yeah, I agree with you, and I have the same concerns that despite having a lot of the evidence and data, it has not been integrated fully into clinical practice. I think there's a number of reasons for this thus far. One, I know in our experience there was initial concern about, for example, implanted wires, implanted devices, or devices that have been left behind, which is not uncommon in transplant patients. I think we've eliminated that concern now, just given our experience with imaging such patients with MRI, and also some of these newer wideband techniques eliminate the artifact. Also, many of these patients, particularly in the acute phase, as you manage them on a daily basis, are sick, particularly with these higher grades of rejection. And then the other challenge is these mapping techniques do require measurement of these images. So, of course, anytime you have a human interacting with an image and manually measuring it, there is a potential for error, and reproducibility may not be consistent. I think as we have more automated measurement of T2 and potentially using various AI algorithms, this will improve. So I think we've overcome a lot of these concerns by referring physicians to use cardiac MR. So again, why is it still not used in clinical practice? Well, I think what will happen is over the next few years, and I don't want to speak out of line because I understand I'm speaking to experts, I think cardiac MR will be integrated into the algorithm along with AlloMap testing and biopsy. I don't see cardiac MR, for example, replacing biopsy, but for example, it may be able to reduce the number of biopsies. So I could see how you might have lower risk patients who, for example, have negative biopsies in the first month or first 3 months, and you revert to, let's say, an AlloMap plus cardiac MR strategy for evaluating acute rejection. This would, of course, have to be entered into the guidelines. I know at our institution, we are looking at revising our own institutional guidelines and will be looking at this in the acute phase. In the more chronic phase, we already are using stress perfusion MRI as a surveillance tool for evaluating chronic allograft vasculopathy. But again, more in that setting. So patients who are lower risk, so who are negative for CAV on the basis of an angiogram and IVUS, will go to an alternate year cardiac MR testing strategy. So every alternate year, they'll get a cardiac stress perfusion MRI, and this will be followed up by an invasive angiogram. And we may even go to a invasive test then every 2 years do the non-invasive test. So I think it's going to be a combined approach, and I think that's probably the way to go. It makes sense to do that. I don't see biopsy going away completely just because it is really the gold standard. But I think we'll probably see a new phase that we enter where we use cardiac MR a little bit more frequently.
Great. Let me ask either James or Rayan to comment a little bit more on this AlloMap testing. I think for folks that are not that versed in transplant management, it might be useful to go into that a little bit more in detail.
Yeah, maybe Rayan, you're probably an expert on this. So
yeah, so the AlloMap testing is basically a gene expression testing, and this is kind of validated for patient mostly after 2 months after a transplant, and morely for 6 months. So basically, it's a blood test. Then they give based on the gene expression of the T cells. It will give you a score, and based on the score, that give us a suspicion for rejection. So these are very good tests they have a very high negative predictive value. If they're negative, the chance of rejection is very low. But the problem is with all these tests, they have a very low positive predictive value in the range of like a 20 to 30%, meaning we get a lot of patients that they have some of their high score, but when we actually biopsy them, they are negative. So I think that's kind of the approach with the imaging, with the AlloMap together. I think it's going to be a key place to see which patient do we need biopsy, which patient we don't, because that's another way to increase the number of the biopsy of the patient, especially chronic one, like after 6 months.
So then, essentially, what you're saying is that that's a biomarker, blood biomarker strategy that has fairly high sensitivity, but not very good specificity. Is that right?
That's right.
And therefore, that's a way you can eliminate some patients to say these are unlikely to have rejection, and therefore don't need more aggressive investigation. The ones that are abnormal then require additional investigation to try to improve the specificity of the findings, basically. And I think that actually kind of segues to one of the other questions from the audience, which I think, the question is, can you make a diagnosis of transplant rejection based solely on cardiac MRI? And I think maybe what they're trying to get to in the end is really more of, what do you do when there's discordance between data? So let's say you have imaging findings which are abnormal, but yet you do a biopsy, and let's say the biopsy is negative. Now, one of the things we know is that there's sampling error in biopsy. I mean, typically, you guys are doing 6 or 8 samples. Is that right?
We do about 3 to 4 samples, and most of them, as we said, is usually going to the septum, the right ventricle septum, which could be a big, like an error, the sampling error.
So yes, you're basically sampling only one part of the myocardium, whereas with imaging, you're able to evaluate kind of the myocardium globally and evaluate all segments of the myocardium. So maybe, James, in your practice at Northwestern, what do you guys do if there's a discordance between imaging findings and the biopsy findings?
Yeah, I mean, well, I think probably like we do with most, most of these techniques, we'll go back and look at the imaging in detail, and sometimes we may see, again, these abnormalities may be more combined to the lateral wall or different parts of the heart. But it also brings up, these imaging biomarkers similar to AlloMap, as you probably know, Dipan, this is a single value that you get of T1, ECV, and T2, and what's normal and what's abnormal. I would say in this setting, what would make me more confident is, say, if we get T2 values that are in the 40s, for example, we would say that's normal. If we get T2 values which are in the 60s, then that's abnormal. It's that intervening period, that intervening area, where it could shift either way, that can be a bit problematic.
Okay, great. There's one other question from the audience here. It says here, do you think every transplant patient should have a CMR at 6 months as routine follow-up? And maybe again, we'll pose this as, in your practice at Northwestern, is this incorporated into a strategy for all transplant patients where you're getting a CMR at some point, or is there a selected group, or how are you deciding? Or how are the clinicians deciding, I guess?
Yeah, so clinically, it is not part of the routine in the acute phase in year 1. So we would do it in exactly the situation that you both outlined, where there was some type of discrepancy, function is off, but the biopsy is normal. It might go to a cardiac MR as the decider. But for CAV, as I mentioned, we do that routinely every alternate year in the low risk group. I think it would be advantageous to do a baseline cardiac MR at some point in year 1. That would be helpful as a comparator to compare subsequent studies to that. And I think we're moving in that direction in Northwestern. I'm not sure how close we are to that at the guideline level, for example. I think we probably need bigger trials. So there is one big trial going on in Europe right now, multi-center study in France, where the data of that is going to become available. And I think that might help drive the guidelines. But at an institutional level, I think many centers are beginning to incorporate cardiac MR a little bit more.
Yeah. All right. Great. We'll give you time for one last question because I know we're running a little bit over.
Thank you. I just, there's some of the studies that show there are some changes of the MRI, especially T2 and ECV, very close to the transplant as far as the inflammatory associated with the post-transplant. And some of the T2 mapping stays abnormal in a transplanted patient even without rejection after, even in the chronically for a long time after. I guess my question is, what are the time that you feel comfortable that we are past that effect of the post-surgical inflammation or effect on the T2 or ECV, that we can use it more for acute diagnostic, like rejection changes for the patients?
Yeah, I mean, I think 3 months would be a good time period, probably at least 3 months. I think one of your listeners suggested 6 months. That might be safer, although it's probably more useful in the first 6 months. But I think waiting at least 3 months would definitely be helpful. And yeah, it is interesting. We saw the same in our cohort. Patients who were just transplants but no rejection and had no history of any rejection episode all had a higher baseline T2, T1, and ECV compared to the controls.
All right, great.
Thank you.
Okay, well, great. James, really appreciate you beaming in and joining us today. And again, I want to thank the audience for all the great questions. James, I know you're going to be with us with our fellows at noon as well, so we'll look forward to seeing you back again soon. And for everyone in the audience, we'll look forward to seeing you back again next week. Thank you very much.
Thank you.
Okay.
Great.
Thank you all. Appreciate the opportunity to come talk to you.
Great.